let's talk about some of the things that work with health behavior change. And again, I'm speaking to people who have many skills in the area of health behavior change. It's what you do. I think the primary message here is to try to broaden your approach from just substance abuse, mental illness. If someone has some of these health screening indicators that show that they have diabetes or they have obesity or dental problems or whatever they might be, to include that in the conversation a little bit and start talking with them about that, and we'll give you a little bit of information around what to look for and what could be of concern that would prompt you to really want to make sure you get a referral to a primary care doc. But just remembering, and again, I'm preaching to the choir on this, the whole focus around motivational interviewing or health behavior change is to take the time to figure out, what does this person care about when they're not sitting in front of you? What drives their daily life? What stresses or supports or great things are they doing when they're not seeing you? Because you're a nice person, they like you, you probably have great conversations, but what's ultimately going to change their behavior is understanding what they care about when they leave your office. If they want to be the best mom in the world, that's probably what they're going to spend most of their time thinking about or feeling guilty about or whatever they're going to think about when they're out there in the world. And that's an entree into a discussion about other areas in their life. And if you can get it impact them in that place, then you're more likely to be able to have them actually leave your office and do some of the things that you suggest. And again, what works for the folks we work for? The same things that work for you and I. If you just look at any of the changes you've made in your life, whether it's to stop smoking, stop picking your nose, I don't know, getting to places on time, all these things that we struggle with, they typically included having other people in your life helping you and getting the support you need and having some structure to the approach you take to changing that behavior. There's a great book that's out now. It's kind of along the lines of Malcolm Gladwell, but this guy, Charles Duggett, wrote. And it's all about habits and how habits drive our behavior, obviously. And there's studies that show 40% of what we do every day is basically just habit-driven. We don't think about it. It's already been encoded into areas in our brain that don't include our conscious thought. And that just drives us through the day. When you get a habit in place, whether it's substance use, whether it's watching too much TV, eating too many fatty foods, whatever it is, if you do it long enough and the reward routine and cues that are driving that routine are done enough, it gets encoded into your brain and it doesn't go away. This is stuff, again, that you guys as addiction specialists know. Habits never go away, they just get replaced. And they will come back very quickly, many times, if they're reignited by certain cues and certain triggers. So the whole approach around habits change when it comes to health behavior change is to really understand what are the cues and what are the rewards that are driving that behavior. And that's hard to figure out because what we do every day is very, very complex. And oftentimes we misattribute what a cue is or what a reward is for why we do something. We might think we watch TV all night because we need to relax, or we actually really like those TV shows that we watch, and that's the reward. But that might not be the reward. And it's only through discussing with people the cues, the routines, and the rewards that are driving their habits and their behaviors do we begin to be able to unpack it and set up goals that are going to help them be able to change their behavior. So to get at those, the real approach is not to get rid of the cue and the reward necessarily, because typically those things aren't bad things. Even if you're someone who drinks a lot and you say reward is the reward for me is a cold beer. If you look deep enough, oftentimes the rewards are other things like social interaction, feeling of calmness, it can be a variety of things, but oftentimes the rewards aren't what we think they are. And they're usually pretty good rewards because they're usually things that are self-preservating for us. So finding ways to really disrupt the routine is the way to really approach changing health behaviors. So if you're going to lose weight, you start looking at simple things that people can do to become more active. And we've heard these stories about park further from the store, right? Take the elevator and not the stairs. And oh, I'm sorry, did I say the other one? You guys are awake. Those seem silly, but if you ask someone to think through why they park close to the store, what would they typically say? I don't feel like walking. I'm always late. I just want to get in there. It's too cold, too hot. Whatever, you know. So, what's the cue? It's usually showing up at the shopping center, and you automatically just look for that front parking space. You'll actually spend time driving around, right? It's programmed, and you're listening to the radio, you're doing things, and you find just the best spot closest to, and then you go in, and you've got that reward. You think it's quicker, it may not be, and you know when you get out, you can kind of hustle over to the car and it'll be close by. So, looking at that dynamic, you can start to see that the reward is really something that you think you're getting there faster. Oftentimes you're not because you're driving around more. Right. So what really is the reward?
Psychological, I think.
Yeah, it's kind of a feeling of satisfaction that, hey, I went through this routine, I can close up that loop. It's like you go and buy a gallon of milk, you know, you just do it, you walk to the back, you get it, you get out. So having the conversations with people about, okay, let's think of a different way to even do a routine like that. When you get to the mall next time, think about why you're driving where you're driving, and think, hey, could you drive a little further away and walk in a little more? And recognize the triggers. The triggers are going to be what? Just pulling into the parking lot. Or maybe the trigger is you're running late. That's a whole other habit to look at changing. And then parking further away to disrupt the routine, and you walk in to the store. And it's that kind of approach of just simple things and helping people understand that you have cues, routines, and rewards associated with all these habits, that you can begin to see people being able to make changes in their lives. And again, this isn't stuff that you guys don't already know, but one thing that we know is that media really tells people to be healthy, you've got to exercise, you got to get a gym membership, you got to lose 100 pounds, you got to sign up for Jenny Craig, you got to do all this stuff. And it really puts us in a position where people just kind of throw up their hands. Yeah. Or even with dieting, I don't know, I can't think of something more confusing than trying to figure out how to eat right. It's very complex and confusing. So the approach that seems to work best as behavioral health folks is to be very simple in the messaging and how you engage people around health behavior change, and keep it really super simple, because people's lives are chaotic enough. Again, people when they leave your office are not thinking about what you said, typically. If they're more in active recovery, maybe. But you really got to be able to get in there and get them to think differently around little things in their lives that they can actually have an impact on. And then reward the heck out of them when they come to see you, of course, right? You get the trophy. I used to have a trophy, a visible trophy cabinet in my office. It'd be like, all right, what are we going to celebrate today? I have nothing to celebrate. Well, let's go through it. You find all these cool things they had done, just even showing up to the appointment where you can say, that was cool. Well, you mentioned, you know, thinking differently about taking the elevator versus, or taking the stairs versus the elevator. I'm obsessed with elevators. The fact that somebody even thought about it, maybe they did take the elevator instead of the stairs, that's a step in the right direction, and that's something to get excited about. Did I do it again? Last week I talked about the straw, the camel that broke the straw's back. So I've got something going on neurologically. So, so motivational interviewing basics, just want to cover these because it's just good to remember these things really apply to any behavior change. So when it comes to helping people with diet and exercise, these things work. These things work with your pets. You know this. Your wives, your spouses, your husbands. So believing that somebody can change is a huge piece of this. Because a lot of times, people don't believe that they can change and lose weight or start living a life that's a little bit more health-focused. And just believing in them is enough. There's a lot of research around why AA works. The main reason why they found AA works is because people come to the point where they believe in something bigger than themselves that links to themselves to where they can actually have hope for change and they can actually change their behavior. So people will come around. You have people that you don't think will ever change. We know people will change and they can change. It's just sometimes it takes a very long time. So helping them believe in and believing in people is huge, 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 huge. Active collaboration, shared decision making, both with you and with their family. So engaging whoever they identify as a support in their life, having them engage that person around the change behavior that they want to engage in. Again, goals, values, and dreams, those things are what drive people. Those are what people are thinking about when they're out of your office, that you need to figure out what they are so you can return to those and have people be thinking about those and linking all your great ideas to what they should do to change their life to those things, because that's where you're going to get your purchase. Resisting the writing reflex, again, I think this is stuff you guys know. If you have pre-thoughts about what somebody is saying to you when they're talking to you, if you have already a conversation going in your head about what you're about to say to them, then you're not truly listening. Active listening is not an easy thing to master, but once you do, it's very powerful. Truly listening to somebody is probably one of the biggest health behavior change techniques you can engage in. Because if you're a complete blank slate, and they got a pile of stuff they need to figure out how to organize, they're going to be better able to do it if they really see you as somebody that they can just pick all that mess up and start organizing. And it's almost like you're a bookcase and there's just a bunch of books, and they need to start categorizing it. If you start giving them recommendations around how to do that and guiding them in different directions, it actually can be more confusing for the person than if you just let them look at an empty bookcase, a blank slate, and start making some decisions about how to do things. So active listening is very powerful, and again, it's things that we're starting to train primary care physicians around. Simple things that you guys even know, that if you have good eye contact and you're truly listening to somebody and you don't have other thoughts going in your head, they will actually mirror your behaviors. So if you go like this, they'll go like this if they're wearing glasses. Or if you go like this, they'll go like this. I mean, look at it in your own clinical practice. If you uncross your legs, they'll uncross their legs. And there's really interesting neurological activities that are occurring there when you're really actively listening to somebody who's talking about the proposition of health behavior change. So using motivational skills is very, very important in empowering the person to be a consultant to you so that they feel as though they have some internal locus of control over their lives. Listening for talk change, and again, some of those things can be pretty subtle, but just someone coming in and saying, you know, the other day I did a calculation of how much money I'd save if I stopped smoking. That's huge health behavior change talk. And you might say to them, well, let's do that now. Okay, do you want to join a smoking cessation group? You start to give your line, and they say, no, I'm not going to do that. But that is the first indication that when they're not around you, they're thinking about this stuff. So either you've had some inroads or they came to it on their own. Look for those little simple things and use them as ways to kind of get inside someone's head. Dealing with ambivalence, oftentimes we want two things that are completely opposite and can't exist in the same space. You know, we want to eat at the Cheesecake Factory, but we want to lose weight. It's like, you can't have both. Damn. Or maybe you can go to the Cheesecake Factory and eat something healthy, but it's probably not good. So helping people understand the fact they want two things that are mutually exclusive is really powerful and really important. And having them choose how they want to navigate that. I want to plant a garden in the middle of winter in Michigan. It's just not going to ever work. I can try it, but it's not going to work. Looking for a degree of commitment. Again, using the commitment and confidence scales, very, very helpful. So, all right, you want to start taking the stairs instead of the elevator. Could you do that 3 times this week? Oh, sure, I could do that. On a rated scale of 1 to 10, what is the confidence you have that you would be able to do that? If they say anything less than a 7, reformat that goal for them, because they don't have enough confidence they're going to be able to pull it off. And that, by having those conversations, you're really mirroring to them their own thinking process that they can start having when they're making decisions about health behavior change in their own life. How committed are they to doing that? Again, 1 to 10. How committed are you to actually doing what you just said? Not that I don't believe you, but you got a lot going on in your life. How much of a commitment is this going to be for you? And using those measures. When it comes to diet, again, it's really confusing. The literature is really confusing. If you listen to the news, there's a new study out that says, you know, carbohydrates are the way to go, and then next week they're like, don't eat carbs. And it's like, oh, come on, I'm just going to not think about it anymore. And that's for us that have relatively stable lives. I'll speak for myself. For the folks we're working with, they got a lot of stuff they're thinking about. So if you can bring simple concepts like this, eat low, and all that means is, what's the lowest food we could eat? Probably kelp, fish, that's real low, that's below sea level. Potatoes, they're underground, onions, carrots, pretty good. So as you move up to higher and higher levels, you get into what? Fruit, which is good to eat, but it's got lots of sugar. So ask people, if they're looking at what to eat low. You know, a cow is much bigger than a chicken. Chicken's probably going to be a little healthier than eating beef. So just simple ways to think through things. Eat for color. And again, Cheetos don't count because they're artificially colorful. But if you look at iceberg lettuce and spinach, iceberg lettuce is pretty pale, not a lot of color. Spinach, very bright color. So when you're looking at fruits and vegetables, the brighter colored ones tend to be a little bit more nutritious. So ask people to eat for color. And again, processed food doesn't count. Divide your plate. I'm going to show you, there's a new campaign out. It's a little bit better than the food pyramid. It's called the food plate. And you've got some handouts on that. Get people to think about that. And the big help with dividing your plate and having the plate division talk is that we really, as U.S. citizens, are confused about portion size. We don't need to eat as much as we do, and we don't need to eat as much as we're served in restaurants. Most of us eat probably twice the amount of calories we need to eat a day. And calories that are consumed around things, through things like sugary drinks, our bodies don't do a very good job of understanding what to do with that sugar. So it stores it in weird ways, or it uses it up really quickly, so we crash, you know, we have our sugar lows. So it's really important that people just start to think about eating smaller, eating less. Halving portions can be really helpful. Just ask people if you can just half your portion. Whatever you typically eat, stop eating a quarter of it, or half of it. You're gonna both save money, especially if you're eating out, because you can eat the next one for the next half for lunch the next day, but you're gonna help your body quite a bit. Eat when you're hungry, not just because of a habit. We get into these routines as I always eat right before I go to bed, or I always eat 3 meals a day. Eat if you're feeling hungry. Even just a 5 to 10% weight loss can be a big difference. So anything you can do to help people to just make little tiny differences is huge. The American Dietetic Association has some great resources that you can look at and share with folks. The good news around the research with exercise is that less is actually more. You don't have to be an athlete and work out a full hour a day to lose weight or become healthy. You only need to work out 30 minutes a day, and working out can include just walking more. So whatever you can do to move around more is going to be helpful. That walk from one end of the parking lot to the front door of the store is tremendously helpful. There's lots of research now to show if office workers who sit all day just get up every 15 minutes to a half hour and walk 10 or 15 feet and then sit back down, there's things that occur when you have large muscle groups, like in your legs, that start moving, that help blood flow and actually will help prevent things like vascular disease. So sitting all day, like we're doing today, I get to stand, is very, very dangerous for your health, actually. There's a lot of research out there to show that standing at your desk, moving around a lot more is a much healthier thing to do. They've done studies where they give thin people twice the calories, and they give overweight people twice the calories, and they see what happens with those calories. Why do the thin people stay thin, even though they've had a big calorie increase? Because they tend to be people that fidget more, they actually move their legs more, burning calories, walk around more, and just generally tend to move more. They actually make up for that extra calories by moving more throughout the day. They actually put undergarments on people that actually registered their movements. So if you tend to be somebody that doesn't move much, you're kind of sedentary, just moving around more is tremendously, tremendously helpful to your body. Lots of cool research coming out, which I think is kind of reassuring, because you don't have to go get a gym membership and become a super gym goer for an hour a day and getting your heart rate up for 15 minutes a day. Those things are good. They will actually help. But just moving around is a huge, huge thing you can do to improve your health. And again, the idea is very, very small things. If you can get people to start thinking differently about their habits, understanding how cues, routines, and rewards work, with one little behavior change, there's a cascading effect that can occur where they start to generalize it to other parts of their lives. And they can become self-actualized, self-motivated to start doing some of this. And I'm preaching to the choir here. I think a lot of you guys know this stuff. Let's talk about any questions on exercise, diet, kind of different approaches to talking with people about it. There's some good handouts that are out there. I think the message as clinicians to the people we serve is keep it really, really simple, and start with simple things you can do. And just losing a pound can really help extend your life and improve your health. As I mentioned, we're going to talk about diabetes and cardiovascular disease, or vascular disease, which includes all the veins and arteries in our body, because those are the big killers. Those are what really are killing the folks we work with. Are people pretty well versed in diabetes or not? Is this something you guys talk with the folks you work with about? Yes, no? Yes. It's always a couple people that say, yep, I got it, I know that better than you, and they're right. They're dealing with it. It's become a very common illness, unfortunately. And there are some trends that are particularly scary. There used to be called adult onset diabetes. Yeah. They don't call it that anymore because kids are getting it too much. So there's things that occur in our bodies that help energy. And again, I'm going to be talking pretty basic. And the reason for that is, first of all, because you're not going to learn high-speed stuff around diabetes in an hour, but primarily because this is how you can talk to consumers about their diabetes. And these are kind of ways to think about engaging with them around kind of your narrative. And that's why some of these slides I won't get into in depth, but you've got them. So use them as kind of your elevator speech if you know somebody has diabetes, to kind of talk with them about that. But again, energy is transferred from what you eat in your gut, it gets into your bloodstream, right? And then it goes to all these organs and it shares glucose or sugar with these organs so that the organs can actually function. So that's constantly going on. You're constantly bringing in energy and spreading energy throughout your body based on eating. And there's this hormone that helps that energy transfer occur, which is known as insulin. And whenever you have a disruption in that insulin process and that ability, either absence of insulin or the inability of insulin to actually transfer that glucose to the body systems, you end up with a condition known as diabetes. It's a serious condition because it affects all the systems in your body. It affects all the organs. And that's why it's so tough to treat, because it's affecting multiple complex systems all at once. And it makes it very, very difficult and very insidious. Two types of diabetes. Type 1 is basically an absence of insulin in your system. Pancreas not producing it. Type 2, where the body either produces enough insulin and it's not getting out into your system, or there's some breakdown in that whole process that's going on. More common type of diabetes, and again, this is one where we're starting to see it showing up in kids even more and more. It used to be that an adult would be pre-diabetic, where you would be at risk for diabetes, and if you didn't do something about it in a year or two, or maybe more, you would develop full-blown diabetes. With kids, we're starting to see kids being pre-diabetic, and they develop full-blown diabetes in months. Because kids' bodies, the way they work, they're younger, they're developing faster, cells are dividing more efficiently, so the disease process actually moves more quickly, just like with cancer. With kids, cancers tend to move pretty quickly because their cells are dividing very efficiently. So really big issues, especially since we've got, what, 2/3 of our population are either overweight or obese in America. Same thing going on with kids. For our folks with serious and persistent mental illness that you work with, are we aware of the fact that the atypical antipsychotics lead to people not feeling full at all and lead to problems with blood levels and cardiovascular disease, which also leads to problems with insulin transference and things they're just beginning to understand. And these are just some basic charts showing if you have somebody who's on some of these atypical antipsychotics, this one's Zyprexa, you're going to see a very high rate of weight. People gain a lot of weight. I worked with a fellow who ate a whole jar of mayonnaise. What did you eat a whole jar of mayonnaise for? He said there was nothing in the fridge, I was just so hungry. I was like, oh man, that's not good. If you are able to take somebody off of those medications, you do see a reduction in levels. And again, this isn't to beat up on antipsychotics or psychiatrists, because a lot of these medications can be quite helpful for people. The idea is we need to just be aware that if they're on this medication, that diabetes and cardiovascular disease can be a real issue, and you need to be talking to them about that. The signs and symptoms, remember what signs are. Signs are things you can see as a clinician that's going on with a person. Symptoms are things that they report to you, things they tell you. Extreme thirst, extreme hunger, obviously they're not getting the glucose they need. Frequent urination, because the body's trying to flush out all this extra stuff that's got in its blood. You end up drinking more and urinating more. It really impairs the body's ability to heal, so you'll see slow healing wounds, dry itchy skin, unexplained weight loss, blurry vision. These are all signs and symptoms to be looking for when you're talking with somebody. If they start complaining about, hey, I'm getting these reoccurring skin problems or yeast infections, you might want to talk to them about, well, hey, have you talked to your primary care? Let's get you talking to the nurse about screening for some of these conditions. And again, this is just to bring home the fact that this disease affects everything throughout the body and causes real problems throughout the body. Making sure people get eye exams and by an ophthalmologist, not necessarily, it's great that they go get eyeglasses checked to see a doctor of osteopathy, I think it's called, optometry, I'm sorry, at the Walmart or at Pearl Vision, but they really need to get in, at least have an annual eye exam, and if they're reporting any symptoms of difficulty seeing, dark spots, flashing, things like that, that they get in to see a doctor right away. Because the problems with diabetes is it produces these aneurysms or hemorrhaging in the back of the eye. This is a picture of the retina, which is the back of the eye. And this is a normal eye. This is one where somebody has diabetes. And you can start to see pre-diabetes, some of these things starting to emerge, which really gets in the way of people's vision, which is a problem. Other thing with diabetes is make sure people are checking their feet. Very, very important that feet, fingers, anything that's distal from the heart, because blood flow isn't going to be as effective and because healing isn't effective, you see people with diabetes who have real problems with feet. Making sure that they check their feet every day. Just take a look at them, make sure they don't have any cuts, because part of the symptoms are they might not feel their feet as much. Making sure if folks have frostbite, that you're addressing that, because a lot of people we work with get frostbite in their hands and their feet. So making sure that they're addressing any conditions with their feet. Making sure people ask them, if you're going to take a shower, how do you test whether the water's hot or not? Make sure they're testing it with their inside of their arm, because a lot of times your hands and your feet won't be a good gauge and they'll burn themselves. So making sure people are having good feet healthy approaches to taking care of themselves, or you end up with the gross pictures of things that can happen to people's feet, which lead to significant issues around amputations. Diabetes risk factors. If you're like me and older than 45, it's a risk factor. If you're overweight, obviously, if you're very sedentary, if you have a family history of diabetes, it's good to know that and ask people about that. If you're a woman who gave birth to a baby that was over 9 pounds, or if you had gestational diabetes while you were pregnant, you are predisposed. African Americans, Hispanics, Native American, all more likely to develop diabetes. And again, as we mentioned, the second generation antipsychotics, atypicals, oftentimes predispose people to having those conditions. Knowing how many people on your caseload, very important. And again, these are some of the slides that I'm going to move through kind of quickly, but it's important that people get your eye exams, get at least a 1-year exam of the feet by a podiatrist, and if not, the nurse in your clinic. I know it's hard to get people in to see a podiatrist, but it's really helpful if you can. Making sure people get the blood tests, at least annually getting a hemoglobin A1C test. Hemoglobin is that red stuff in your blood that transfers oxygen and different nutrients. A1C is adult 1C, which is just a type of binding mechanism within the blood that allows that insulin to work and transfer things. So the hemoglobin A1C test is a really good one because it's able to look back a couple months to see how good the blood sugar has been in this person's body over several months. The regular finger prick, you get a glucose test, sometimes fasting, sometimes not, is really point in time, and it's not as accurate or as helpful. Yes?
I was wondering how many folks actually do any primary health screening right now. And I guess I would assume a lot of people don't in the substance abuse world. Is there an expectation that we should be doing this and how we would be reimbursed? And those are.
I asked earlier if they were, and they said they were. We had about 75% of folks said that they were doing health screening, right? Mm-hmm. Those NASH-BID criteria that included medical history, blood pressure, BMI, cholesterol, A1C. The nurses would primarily be the ones doing this, or you guys would, hand out a health screening form of some sort. Do you guys do that?
Once they do the screening, you guys do anything with it?
Yeah, having a kind of a system in place where you take the information and actually transfer it is useful. But are people doing that?
Yes.
Do you actually, after you do the health screening, is there a protocol for what to do with the information once you get it?
Well, again, when you look at a holistic approach, we make recommendations that if you got a physical concern, a medical concern, when you do it the way it's supposed to be done in a healthy approach, holistic approach, then we make recommendations. And we do, and that's a part of discharging as well as making recommendations. But now if the client follows up with it, that's up to the client. But I know all over the courses of the years I've been in the field, we have always said, call your primary care physician. When was the last time you had a physical? Call your psychiatrist, link them to a psychiatrist, link them to all the various needs to treat the whole person. But it's still up to the client.
Yeah, and that makes it tough.
Yeah, but now some counselors go as far as making the appointment for the client.
Would you ever go on, so most of the work you do with these health screening data or you know, if a person tells you they have diabetes,
Yes.
would be around referral and suggestion to the consumer.
Yeah, for referral and recommendation.
For
yes.
referral and recommendation. So would you ever go to a primary care doc appointment with somebody?
Have I?
Would that ever, well, not you,
Well, I
but
have.
in general,
I
would,
have.
is that something you guys can do?
Yeah, I had.
You know what?
A part of the process about when you're working in the community as case managers, and some people are more flexible with their jobs. It really depends on the agency, because we know sometimes clients will not follow through on certain things.
Well, actually,
So-
we know that
Yeah.
like 70% of the time they won't. They've done studies where they had a substance abuse mental health treatment provider upstairs and a primary care office downstairs.
Yeah.
And they referred the person to the primary care office down the stairs.
And they didn't go.
They didn't go. Only they lost 40% of the people who just kept going down and out the door.
And that's
So
why-
if you're referring somebody across town, it's just not going to happen.
Well, then also that's where family members and significant others come into play. This is
So-
why you include family, significant others, somebody they care for. So it's a lot of strategies that have been and that are implemented. And again, though, it's up to the consumers. I
Well,
mean,
it's up to the consumers, but I think it's also up
to
to your
accept.
administrators
To
to look
accept.
to accept it, yeah, because they're going to go do what they want to do.
right, that
But
old
there are,
saying that you can take the horse to the well, but you can't make them drink the water.
right,
But you know
but you
what?
can also do some pretty creative things with that horse at the well. One of the things that's going on in the field now is, as I mentioned, this bi-directional, where they're putting substance abuse staff in primary care clinics, who will actually do screenings and treatment right there. But other things they're doing is making sure that agencies like yours have pretty good protocols around what to do around positive screen for diabetes or something. And again, it's basic stuff, starting with how many people on your caseload have a primary care doc, how many people have seen that primary care doc in the last 3 to 6 months, and how many consents do you have to talk to that primary care doc. You know, starting with those basic pieces, and again, I don't think this is the clinician's responsibility to kind of set up protocols for this stuff. I think it's the administrators who should be doing that stuff to support you guys. But having some protocols around how do you coordinate that care a little bit more effectively than it currently is to get a better hit rate around referrals. Down here?
What I find to be the case a lot of times is a lot of these medical conditions have preceded their substance abuse.
Oh, yeah.
So at some point in time, they were getting treatment and seeking medical help for it. And then once they started using, they stopped. So then once they come into treatment, and then when an assessment is done, and you find out that they have this in their medical history, they have diabetes, they have hypertension, they have cardiovascular disease, and then like someone had mentioned earlier, so you make a recommendation and you do a referral, and it's literally up to the client to do the follow through. But what I find to be true more often than not is once a person stops using, and then the symptoms of everything else begins to show up, more times than not, they will follow through. Now, whether they stay on that course or not, it remains to be seen, but because they know they already have this predisposed condition, and when you're using it, of course it gets worse.
Right.
You know, it's chronic and it's progressive and it's constantly getting worse. Once you stop using the drugs, and then the symptoms of the diabetes and the hypertension and the cardiovascular disease begin to show up again, then it has to be addressed. So I think, like you had stated earlier, it's about education, and there has to be some kind of joint collaborative effort with all the care providers, everyone. You know, very seldom can you find all the caregivers under one roof where they can just go, the client can go
Right.
from place to place to place, and everything can be addressed.
Right.
That's very rare and not common at all.
Yeah, I mean, it's like recovery. It's small victories, it's
Right.
small successes, and whatever you can do in your regular workflow to just make that referral a little stronger, whether it's more education for the person, like you had mentioned, including family, talking with administrators about, hey, if you want us to start doing this new primary care referral stuff better, we need data to know who on our caseload has a primary care doc and who doesn't. or who has diabetes and who doesn't, or who's screened positive for this or that, to kind of give teams more information about how to proceed with this. Because it's not fair as clinicians for you guys just to be trained around this stuff and then expected to go and fit that into your day as far as developing new protocols, procedures, or leading change within your organization. That's for the leadership.
Let me say something as far as with mental health. A lot of times you have to look at why the patient, I understand that substance abuse mental health is a little different, but then when you have an individual that's in both categories, of course it's unique, but with the mental health, as far as giving them, providers telling them to go here, go to this appointment, it's a little bit different, because one thing I found by working in mental health at one point is that there are certain barriers that someone with mental health may have. They could have had bad experiences going to a doctor, or number one, you can sit down and ask them, why are you not going to this this appointment that you know, because they're not stupid, you know that you need to go to. And I found that when I work with people, with individuals with mental health issues, they said, well, I'm not treated right there. Seem like everybody else is seen before me, and they overlook me. And then there was some that said, well, they make my appointment when, especially the ones that was coming to our program that would get fed, and you know, that could have been their only meal at the time for the day. They said the person at the desk always make my appointments during lunchtime, and I keep telling them I cannot make that appointment. Yeah, so it could be anything, and those are things that as a clinician you have to ask and just say. You can't just give an appointment and say, here, go there. You got to ask and say, is there a reason why you cannot make this appointment? Do I need to at least go with you at first? And when I found that when I did go with some of my patients to the appointments, they were telling the truth. They were being mistreated. They were being mistreated, and when they tried to explain the situation, the person said, just sit on over there, just sit on over there, we'll get back with you. And then everybody looking at them. You know, so it makes it very hard for them to go, to just up and go to appointments.
And that's again why I think it's so important that this isn't a problem that clinicians are going to be able to fix alone. It needs to be leadership in the organization. It's kind of a different conversation, but leadership within the organization, reaching out to these primary care clinics and saying, hey, we're all treating the same folks. We all have the same mission for people to get better. We need to do this better. And then some agencies are starting to put primary care into their clinics so that the primary care can actually be right there. So you can do what they call a warm handoff. Is, okay, after I see you today, I'm going to walk you down and you're going to see the nurse here. Is that okay? As opposed to giving them a referral.
And that's what we did as a program. We actually set up something with the local hospital, explained the situation. That was a couple years ago. And like I said, this was mental health. And then it was set up. We didn't really have any problems anymore, where the patients were able to get on the van or the bus and go to the appointment and feel safe or feel good about being able to go to the appointment on their own. So there are other, like you said, things, barriers and strategies you have to do than just say, here, you go to your appointment, you don't, or whatever.
It's a tough word, because it usually leads to not good outcomes. Yes, sir.
Yeah, this has been my experience with the some providers that I actually work with, that the OMT programs seem to do a whole lot better job in terms of coordinating care with the medical, the psych, the opioid methadone programs. They seem, just my experience, they seem to do a much better job in terms of coordinating care outside of just the substance abuse. And what I also find in those programs, that they seem to address some of the psych issues much better than some of the mental health programs that some of those individuals involved in, because it's just that it's more focused just on the medication, as opposed to when you get into the medical model, as opposed to in the substance use. I mean, these folks are actually involved in individual therapy as well as group therapy. And then there are other resources that these OMT programs have. Now, the standard outpatient programs, I see just in some, not all of them, but I see very little of this holistic approach.
That's a very interesting point. It makes sense if you think it through. And a lot of the straight mental health programs don't want the MAT type clinics or things in at their sites. So they've kind of had to forge their own their own clinics and really link and coordinate well. Yes?
Yeah, as an administrator, at
Oh,
program.
administrator, yes.
Yeah, as an administrator, I find that I'm a community person. I find that I go out to develop relationships with different
That's what it's all
programs.
about.
Because that way, if I have a name, they see my face, I see their face. When you're talking about communities being involved, it's really important to develop relationships, so that way we can train our counselors, our support staff. This is the name, this is the number, this is who you talk with. And I have always been, because I started out as a social worker one time and a case manager, but over the years in the early 80s, I found that going out in community, doing community outreach, as the administrator, people are more receptive to working with our clients who have drug addictions or who have mental illness, with all these other medical issues that come along with this substance. And again, the holistic approach is get all these bodies and community providers involved. But it takes the administrators to get out the office,
Right.
go out there into the community, and build these relationships. Yeah, the administrators got to go out there.
In some places they call it a rolling start, where as an administrator, you go to the community members where you have the best relationships, and you start working there, because it's going to be easier. And you start seeing how you can create leverage and create a vision. Because creating a vision as an administrator or leader of an organization is about the most powerful thing you can do. Because leadership's about creating a vision that other people can see as their own and want to get behind. And really painting a picture of what our clinic could look like if people didn't die younger, or if we had more primary care involvement. What would it actually look like for somebody who showed up for care? And casting that vision so that people start to say, yeah, that's what we want. And yeah, we identify with that as a community provider, and we'll link with you around that vision.
Yeah,
Yes?
I have a question. What do you do if one of the barriers is lack of insurance? There are people who receive SSI because they make a penny more. They're not qualified for any kind of insurance. And the state has taken all the fundings. There are people who pay like sliding scale.
Huge. Well, we pray that 2014 actually happens with more people coming on Medicaid. Do you guys work with federally qualified health centers much, or do they have them in your communities? Those still have sliding fee scales where people have to do some copay, which often prevents people from, even $1 or $2 can get in the way of someone, getting into an appointment. So that's where these relationships between primary care and mental health and substance abuse become very powerful, because federally qualified health centers can actually bill more for mental health and substance abuse services than mental health and substance abuse services can. They get more money. So developing a relationship starts to create this dynamic where you could say, well, why don't we put some of our staff in your clinic, we'll bill at your rate, get more money, and we wouldn't have to deal with the co-pays as much. We could actually deal with letting people have free services, and it wouldn't hurt us so much. And then take some of your primary care people and put them in our substance abuse clinic, and you can bill at your own rate in our substance abuse clinic, because the law allows that. And we start doing some of this back and forth collaboration and start sharing some of that money. Because there's money out there. You just got to create the partnerships to be able to say, let's start billing as much as we can in our current system. And again, the money's going to be shifting and changing as health reform rolls out. And then taking those cost savings and giving them to consumers, especially the ones that don't have money to pay for health care. So there's a lot of creative stuff going on out there in the world, and you guys bring up very good points. You're in the middle of a very tough situation. I often think about it as, between new electronic health records and health reform, as a clinician, you're just like getting hit by both sides of transition times in our healthcare industry. There's huge transitions going on right now. It's almost like, boy, I wish we could just wake up in 5 years and have all this stuff done, but that's not going to happen. So treatment for diabetes, obviously pretty straightforward as far as really needing to monitor the blood sugar levels so that they don't get too high or get too low, and talking with people about what that means for them. Diet and exercise can help regulate that very well. So having just simple conversations about what can you do? Can you eat low more than eating high? Well, what does that mean? Eat more chicken than beef this week. Can you just do that? Yes, I'll try to do that. That's a start. So really letting people know that they don't need to lose tons of weight to actually impact their diabetes. Just losing a little bit of weight will create wonderful benefits for them. Get them moving around a lot more, and just making sure that they're getting their blood sugar checked on a regular basis, whether that's that fancy A1C or just the finger prick at the nursing station or at home if they get training around that through their primary care, so that they can get those symptoms taken care of high or low blood sugar. There are oral medications and injections. If people have to use an injection, there's quite a process of going on around doing an injection correctly and managing the insulin and making sure it's refrigerated, all these great things. So make sure you're talking to people about, hey, do you got that covered, or you need us to give you some support around that. You can talk about the ABCs of diabetes, which are A1C, blood pressure, and cholesterol, making sure that people understand that they need to keep these things in check. ABCs, 1, 2, 3s, there's a lot of different ways to think about this stuff that are easy for people to remember. There's some in the handouts you guys have. Use that information to share with folks. Do people aware of the body mass index scale? You guys, I've heard many say that you guys do this. This is a ratio between weight and height, which gives people a general idea of whether they're overweight, underweight, or obese. It's not a perfect measure. There are some people, especially big guys that are very muscular, who will come across, according to this, as being obese when they're really not. So it's a guide, but it's a good guide, and you should use it and see if people are overweight or obese, and if they are obese, to really make sure that they get into some wellness programming or they're addressing that issue. Higher BMI, more likely you are to have problems with developing diabetes, cardiovascular disease. If you already have cardiovascular disease and diabetes, it just makes it much worse. Again, this is just some languaging you can use around reading lab results with the people you work with. And then my diabetes care record example, I think that's part of the packet you have. There's a lot of great resources out there to support people in diabetes care. And do you guys do labs on site?
No.
No? Okay. So that's another administrator thing to be thinking about. You might want to develop the capacity for your nurses to do labs on site, or having somebody come in to be able to do that. You can bill for it. Larger conversation. So vascular disease, again, I want to give you some quick information around that because it's a big killer of folks. And vascular, again, has to do with the vessels or the pathways throughout our body that blood flows through. Okay, this is how we're talking with people about this stuff. Vascular disease includes cardiac disease, it includes stroke, it includes any condition that has to do with your arteries, your veins, getting clogged up, not working efficiently. So anytime someone talks about having any condition related to vascular disease, it's a big problem that needs to be addressed. It's the #1 killer of people in the world. Cardiovascular disease, or coronary artery disease, obviously has something to do with the heart. A lot of people don't know this. And I think we make assumptions sometimes because we're educated and middle class and have had health courses and things like that. A lot of the folks we work with have never had any real health literacy training. So just this whole notion of what cardio is and cardiac makes no sense to them. So helping them understand that the heart is in the middle of their chest and it gets clogged up with cholesterol and things that are bad when they eat bad foods can be really helpful to someone if they really never had a grasp of what that all meant. So for you, it's really, you're explaining to them when people have vascular disease or coronary artery disease that the real problem is that all the tubes that the blood flows through the body are getting jammed up with this plaquey mucus stuff called cholesterol, which causes the heart to have to work harder. And you can use analogies like, or examples like a hose, or even putting your finger under when the water's coming out of your faucet, just put your finger there. What happens? The water comes out a lot faster, right? And that's because it's under a lot more pressure, because you're pushing down on it. Same thing happens when the walls of your arteries get all clogged up. It produces this pressure inside your body, which makes your heart work harder and gives you this thing called high blood pressure. So having conversations in that way with people can be really helpful, because a lot of times they've just never had the opportunity to have those. It's also helpful to use diagrams like this and show this is just like if you were to kink off a hose, a garden hose, or put your finger over the faucet. It would create pressure, which makes it harder on the heart. But it's also good to remind them too that this plaque buildup not only just produces pressure, but it makes this whole area of the artery brittle, so that it eventually can break. It can actually break, just like if you had a brittle tube and it broke. And that's what happens a lot of times when people are in car accidents and things like that. You might say, you know, blunt force trauma, that sort of thing. If your arteries are so clogged and so brittle, any shaking of the body can dislodge an artery and actually cause bleeding. Have people heard of the aortal aneurysms?
Yes.
Where people get the plaque buildup in this very large abdominal artery, and eventually what happens is it breaks. It actually just kind of becomes brittle and breaks. So it's not only a problem in the vascular system around high pressure in the system, but also it makes your veins in your heart more brittle, which is a real issue. It's not good. Heart attack, sometimes known as a myocardial infarction, or in medical records you might see MI. It's not mental illness, it's a heart attack. Good to explain to people that the heart is a very powerful muscle that exists in the middle of your chest, and 25% of the blood each time it pumps goes to your brain. The rest of the blood goes to the other parts of your body, including the heart itself. So although the heart pumps blood, it pumps blood throughout the body, it pumps blood to itself, very importantly. It needs blood too. And whenever those arteries get clogged up, it prevents blood from getting to the heart, and the heart muscle can actually die, or it can just become so stressed that you get pain. And that's the condition of having a heart attack. So letting people know that can be very, very helpful to them. Stroke is the same kind of concept, but it's happening in the brain, where the brain is prevented from getting blood flow. And what happens is you either get a short-term reduction in blood flow to the brain that affects the brain, or a complete stoppage of blood flow because of a blockage, or an artery or a vein breaks open. And that causes something called stroke. Some people will describe it as a shock. Older generations know of this as they had a shock. But it's basically the person's had a stroke, and there's some pretty good signs and symptoms for people to be aware of around those, that you can both be aware of when you're doing a clinical assessment with somebody, or you can just make them aware of it. But the signs and symptoms, the slides got mixed around. Oh, we'll do signs and symptoms of heart disease. So the signs and symptoms of heart disease, and many of us know this, but again, a lot of us don't. And some of the signs that we see when we do blood pressures on people, again, those are the things that we can see in the body that the person might not be aware of, are things like high blood pressure that people don't feel. Cholesterol, which is done through a blood test, if cholesterol is high. For the symptoms of a heart attack, we get people complaining about pressure on the chest, become very sweaty, feeling of impending doom, nausea, vomiting, a lot of different symptoms that can occur, but they're typically, when you ask the person what's wrong, they'll be able to tell you something is just very wrong, and it's a lot of times they can associate it with their chest. So they can have pain radiating to their arms, their backs. There are conditions known as a silent MI or silent myocardial infarction, where people just have pain in one arm or they have pain in their back. They're actually having a heart attack. More common with older people over the age of 70, more common with women. Also, women tend, and I think it's more of a cultural thing, to not complain as much as men, frankly, and will attribute actual cardiac symptoms to other things. So they'll say, oh, I'm having a GI problem, or my back hurts, or something along those lines. So it takes a little bit more work sometimes with women to kind of get to the fact that they're having a heart attack or have symptoms and signs of a heart attack. Also, more research has been done around men's signs and symptoms of cardiac arrest and heart disease than with women. So that's part of why a lot of the common signs and symptoms we've learned apply mostly to men and not so much to women. But cardiovascular disease kills just as many women. It's pretty devastating. Signs and symptoms of stroke, weakness, numbness on one side of the body or the face. You can see facial drooping. People may or may not notice it. Oftentimes they will. Slurring of speech. You can have people with sudden dizziness, loss of vision, bad headaches, difficulty walking, difficulty even articulating things or talking. Anytime you have any of these symptoms in your office, it's just very important you get, if you've got a nurse in the clinic, you get that person involved and you get the person to the hospital. This is just a slide showing stroke and what it can look like. So you can have a blockage that occurs due to either a blood clot or oftentimes cholesterol plaques build up, and part of the brain just doesn't get the oxygen it needs, and it could be just a temporary thing and the symptoms go away once it clears, or you can actually have a complete break where there's a bleed out in the brain. So again, a lot of people don't necessarily know this stuff. They've heard some of this stuff, but they might not be fully aware of it, and it can be some of the languaging you use with them to get them to agree to engage with you around going to a doctor. So reducing the risk for cardiac disease or vascular disease, of course, not smoking. It's probably the #1 thing people can do because of the stress smoking puts on your vascular system. Controlling blood pressure, very important that people monitor their blood pressure. There are very good medications for controlling blood pressure that work, that don't have a whole slew of side effects. So getting people on medication for high blood pressure can be very helpful. Again, getting people to exercise, and by exercise it doesn't mean having to exercise a lot, just moving around more. And this has to do with you all too. Just moving around the office more every day, walking more can be very helpful. We've got a lot of technology that helps us now. Even remotes for TVs and remotes for garage doors have led to us not having to burn as many calories. You might only burn 5 calories when you get out of the car and open a garage door. That used to happen in the 60s and 70s before garage door openers. So you got to think of all these little things where we've made improvements to make our lives easier, but it has ended up with us burning fewer calories. So whatever you could do. TV remote, perfect example. You used to have to get up and Dad used to be, Jeff, change the channel. I get up and change the channel. But just simple things like that have reduced our calorie expense, our ability to use calories. So whatever you can do is going to help. And again, healthy diet, there's some handouts for you related to that. Want to talk a little bit about high blood pressure. How many people get their blood pressure taken when they come into the clinic? Do you guys do that regularly? Yeah? I think this is an area substance abuse does a little bit better than just straight mental health, because a lot of times you guys are trained in that for people who are withdrawing, you got to do the locus, you got to do the blood pressures, things like that. Are you guys trained yourselves to do blood pressures at all? No? Okay. And having health fairs can be very helpful. Do you guys ever have health fairs? We've got a health fair lady here. Health fairs, oftentimes what you see is if you get 100 people coming through a health fair, you'll have 3 or 4 people that have to go to the emergency room, because you'll identify either signs and symptoms of a heart attack or often high blood pressure, where people have blood pressure that's so high that they need to be seen in the emergency room right away. These are the same people that are showing up in your offices to get care from you that, again, don't have symptoms because they're not feeling it. But if you look, there will be signs there showing that they have serious health conditions that need addressing probably pretty quickly. Relaxation techniques. Do you guys engage in any biofeedback or relaxation techniques?
Yes.
Good. Very powerful intervention when it comes to vascular disease is meditation biofeedback. Anything you can do to help the person, even if it just includes learning how to deep breathe on a regular basis when they're stressed, taking very full deep breaths, actually helps the cardiac system, the vascular system, reset a little bit and reduces the pressure on the system. So using any of those biofeedback or mindfulness techniques in your training and in your work with people is very, very helpful. Cholesterol, make sure people understand what cholesterol is and what it isn't. Some people get confused between cholesterol and blood clots. What's the difference? They hear stories about people that have died in their family and the reasons why. So it's nice to have a conversation with people about what all this stuff means. There's a lot of confusion out there around good cholesterol versus bad cholesterol. The important point is to just get your cholesterol tested. Get people to get their cholesterol tested. There is a lot of literature around good cholesterol versus bad cholesterol. The HDL cholesterol is supposed to be the good cholesterol, but again, it's more important that people recognize foods that have high cholesterol and that they get their cholesterol checked than it is necessarily that they get a course in different types of cholesterol. For you all, though, it is very helpful to recognize some of the issues related to cholesterol and how to reduce it. Here's some simple guidelines that you can give people around how to eat healthy with regard to cholesterol and reducing cholesterol. There's a lot of confusion out there in the world around the best diets to reduce cholesterol. Stick with these simple guidelines with folks, and it can be very, very helpful. There's been talk that the reduction in trans fat has been helpful. There's starting some research coming out now. There's cities and food producers have gotten rid of trans fat. You'll see that on a lot of products where they said, hey, we got rid of trans fat. Trans fat may never have been in the product in the first place, but they're taking credit for it, which is great. But if you can get into a conversation with people about cholesterol and they're somewhat sophisticated in how they think about their diet as it relates to cholesterol, it's good to let people know the differences between monosaturated fats and more complex saturated fats, high saturated fats, and making sure that if they have a choice that they're going with things that are monosaturated like olive oil, because the hydrogen compounds that hold those molecules together break apart more easily and flow through our system better than those more complex ones. So having conversations about eating and cholesterol, especially if someone's screened positive for high cholesterol, is very, very helpful. Blood pressure, again, very basic. It's nice to have a conversation about what blood pressure actually is, because a lot of people don't know what it is. And the pulsing of the heart, when the heart actually squishes blood out of it, is what you feel on your wrist when you check your pulse. It's the squirting of blood through your body. 25% of the blood that comes out of the heart goes up to the brain, the rest goes out to your whole body. And when you get your blood pressure taken, that beat you feel, that pulse, is actually the pressure reading for the larger number, that 120, that systolic, that high number. And when your heart's at rest, the pressure is still throughout your body. That's that smaller number. The body at rest, there's still pressure in that closed system of all your blood vessels, and that's that lower number. For an easy way to remember it is systolic is high, diastolic, D is down. It's the down number, it's the number below. 120 over 80 is typically the pressure people are looking for. If you get too high or too low on that, you've got issues. And it's worth making sure that people are aware of that and you're working with them. Here's some more information around cholesterol for you all. Just good to know these for your own good. And if you do get a hold of any lab results, do you guys ever have lab results in your records at all? Oh, you do get to see lab results? So take a look at those lab results. They're really quite easy to read. I mean, I'm not saying you should read lab results and tell patients what they need to do with them. That's for the doctors and nurses. But you can become very educated yourself just by looking at those lab results, because they're somewhat dummy-proof, where they'll tell you if the range is high or low with colors or with arrows, you know, saying, hey, this is an issue. And if flipping through somebody's chart, you see a lab result, pull it out, take a look at the A1C levels. Anything above a 7, and that information's in here, is going to be a problem for folks. Cholesterol levels, they're all right here. If you see any of those are high, then it's worth having a conversation with the person about their lab results that you noticed in their chart. And bring them with you if you go to a primary care doc appointment with the person, and make sure that it's addressed. Because again, primary care moves quickly. They might not get to the high cholesterol because they're caught up in the diabetes. But you might want to say, hey, and then I noticed in these labs this is high, should we talk about this too? It's often helpful if you can go and model that behavior for the person you're working with, so that you can trigger the conversations that need to happen when you're in a primary care appointment with them. Just want to wrap up before we have some question and answer and get into a little more discussion. I think it's worth spending some time talking about systems change and what you can do at your agencies to kind of change your workflow during the day. I just want to make sure, and this is kind of, I think it's a prelude into the afternoon discussion, what we're learning, and I work with soon to be 94 grantees, SAMHSA grantees, that got about $500,000 to do health integration. So there's substance abuse centers that are merging or linking with primary care and developing wellness programming and healthy eating groups and things like that. What they're finding is the best way to engage people is to use motivational interviewing, but also to use consumers, peers, coaches, sponsors, to engage people around healthy lifestyle change. It's because, for obvious reasons, they have lived experience with this, and consumers themselves really engage a lot more easily with these folks. So if you can include consumers, sponsors, whatever you want to call them, in your services, it's really helpful. People who have addressed their physical health needs do find it easier to recover from substances. So while somebody's primary concern might be, their raging substance use, if they have diabetes, if they have high blood pressure, it's incumbent upon us to make sure that we're at least covering those bases a little bit when we're meeting with them, so that we're getting them some support around those issues. Because if those things get addressed better, they're going to be able to address their substance use condition more easily for them. If your services are truly integrated, meaning that you've got either a very strong referral network where they know who you are, and when you refer somebody to them, you let them know and they tell you if the person didn't show up, or you have co-located services. We're getting a lot of reports from folks, not surprisingly, that access to care was their biggest issue. It was, their doctors being able to get in and see a primary care doctor was huge for them. So access was a really big issue for them. Being able to talk with their primary care doc about what they'd really like to focus their treatment on, as opposed to what the doctor says they need to do that day, was very helpful. In the primary care field, there's a great book that was written called Change or Die. Did anybody see that book by Alan Deutschman? He did a study looking at why do people who have chronic coronary artery disease continue to smoke and eat steak when they know if they do this, it'll kill them. And we all do this. We know what we need to do, and we don't. Why is that? And his investigation into how the healthcare field helps people make those health behavior changes found that the medical community typically uses fears, facts, and force to get people to change. So, and we're part of the medical community, so we do this. We scare people by saying, oh my goodness, you've got a serious condition that needs addressing. And we talk with them about the impact it's having in their lives. We use facts. You know, research says you should do this. We've got lab results that show that. We've got a screening tool that shows this. I know this happened to you last week when you engaged in that behavior. I have facts to show that what you're doing isn't good for you. Fear, facts, and then we use force. And sometimes we force medicate people, but there's usually a more subtle way to do it. We really carve out the healthcare industry as the high priests of knowledge, right? We wear white coats, or we sit behind our degrees in our desks and say, you know, hey, we know stuff you don't. You need to listen to us. So fears, facts, and force does work to some extent. And it's our primary mode in most healthcare specialties. I think less so in substance abuse and mental health treatment, because we use the other three things he found, which was reframing, repeating, and refocusing what folks are doing, which is basically motivational interviewing, where we're reframing what's going on in that person's life so that it relates to them and who they are as a person. We're refocusing them around their perspective on their life and what they can do to change it by, you know, giving them credit for hard work they're doing and refocusing them away from the negative things in their lives. And then we're repeating it. I mean, how many times have you had someone come to you and say, I got the greatest idea, I'm going to do X, Y, and Z, and you're like, well, I've been telling you that for 2 years. Where'd you get this great idea? Oh, my friend told me. Oh, great, thank you. But repeating it, as human beings, we need that repetition in order for things to work, because we are creatures of habit, and habits are created through repeating behaviors and repeating thoughts over and over again. So having the common courtesy to move away from fears, facts, and force and into more, you know, a person-centered approach was something that consumers reported liking. They saw it as, you know, it seems a lot more courteous when our primary care docs and our mental health and substance abuse providers work more closely together. There's better coordination of care, and there's better overall care, which isn't shocking. There is some concern in the consumer world about this being a return to the medical model. There was a lot of concerns with evidence-based practices just being too prescriptive and not recovery-based. I think that speaks to this whole idea that we need to be mindful of the fact that primary care, specialty, physical health care is very medical model based, and we're in the middle of it. So we need to help them move away from this just being kind of fears, facts, and force prescriptive, and helping our consumers understand that that's their perspective, and that we're helping them engage them in a different way that talks about whole health recovery, and how, you know, it's not enough just to address one or two acute symptoms. We need to look at spirituality. We need to look at what recovery means to people, how they define it as a person recovering. Those things are very important. Again, there's a lot of evidence out there now to show that better integration of primary care and substance abuse and mental health services is effective in controlling for costs and producing better outcomes. That's stuff we talked about with Wagner. You know, having people that are actually activated to produce their own health behavior changes and that actually have observable, objective, measurable, good outcomes as a result of the care they're receiving. Integration with primary care also helps us as providers, because it's going to bring more people to our team to allow us to better help the people that we serve. So anything we can do around integration to support that is going to be ultimately helpful to us and to the consumers we serve. And again, it is part of our job today. This primary care stuff is not going to go away. Our coordination with primary care and our needing to talk with consumers about their physical health conditions, that's not going to go away. If anything, it's going to become more structured and more measured as things like NCQA start ramping up more. So please be thinking about how you can fit this into your workflow. And then I've included a couple resources, websites that are very helpful that you can use or give to consumers. And you've got the handouts. So we've got a couple minutes left. I just want to open the room to discussion, and if people have questions, let's take those now. And I do want to spend a little bit of time talking about organizational change if we can, and how do you actually take all this great stuff I talked about and get back to work and not replicate that Dilbert cartoon. You ever see the Dilbert cartoon where he's got the 3-ring binder? He said, I achieved a great thing today. I learned many things in this training, and all that knowledge will forever live on my shelf. And he puts it on the shelf. So a lot of times these conferences and trainings, you know, you learn about great stuff. Yeah, the guy talked fast, he was okay, got some information. But then how do you actually, when you get back to work and get into your own habits, which occur throughout your day, because you each have your own workflow habits. There's something you do every day that's the same, many things. How do you change that to incorporate some of this stuff to be able to provide better care and maybe even have a better time at work, having more fun at work? So I would like to have that conversation as we can, but let's just open it up to questions. Any questions? I know it was a lot of information. Is this doable? Oh, I got a giggle. It's doable. Are you smiling and giggling because it's just so doable and this is such a great idea?
No, I think the biggest problem for my program, I run an OMT in Baltimore City, it's a pretty large program, and we have probably close to 600 patients, and of the ones that are insured, more than 2/3, there are 500 or more well, not 500, but however many patients, primary care physicians, and just getting, and they're all in different clinics, and just getting the physicians to actually engage with our physician or our nurse practitioner to get information has been our biggest challenge. And you know, just to get them to call back or to fax the records or to get the things that we need so that we can properly coordinate care.
Yeah, and that's why you know, there's great stuff you all can do when you go back in your one-on-one interactions with people and bringing this health information to them. But it's incumbent upon the administrators in the room and you all to go back and say, you know, this guy came and he said that it was, if all this health reform stuff's really going to work, that the leadership of the organization, the quality improvement teams within your organization have to be driving this, because you can only do so much as a clinician with a big caseload, and you will do great things, and you will coordinate a little more with primary care. But in order for the system to change, you need leadership to be talking with leadership in other components of the system. It's the only way it works, and to have a shared vision. And what we're finding is, in some communities, it's relatively easy because we've got substance abuse providers, mental health providers, primary care providers. They're already talking a lot, they get along pretty well, and they just need to do a better job of that. Then there are other communities where there's actual turf war going on, where people are thinking the other people are stealing their funding or get too much funding, or you know, they just don't want to work together at all. And in those situations, it's incumbent upon the leadership to look at the ways in which your organization, as a substance abuse provider organization, can go after credentials or ways of becoming a better delivery of healthcare services. And what that means oftentimes is looking at becoming a federally qualified health center yourselves, or a lookalike center, doing some pretty radical things. Because if you don't, especially substance abuse providers, you're at grave risk with health reform.
In Maryland, the primary care people are not at the table, but the substance abuse and mental health people are at the table, and we are right now in the process of integration. They just released an organizational chart that will, that's outlined what the integration is going to look like. But it's difficult to get the primary care people at the table, at least at this juncture. So we are going to become an FQHC.
And a little what's going on with primary care, and it depends on the market you're in or the community you're in, is they're all rallying to become accountable care organizations. So the future, if it goes this way, is you have accountable care organizations, which are kind of like the health home for all the health homes. So they all link up to that. And then off the accountable care organization, you've got the health information exchanges, right, that are going to be managing the data and linking all those clinical records together. And then you've got the health insurance exchanges, which are going to be defining the funding and distributing funds to the ACOs. The ACOs are primarily hospital systems right now, and they're jockeying. So some of their primary care providers are kind of like, well, we can't do anything until we know what's going to happen. So they're kind of keeping everybody at a distance. So some of that is going on, but it's just really important that you guys take credit for the great work you do and get to the table. So if there's health information exchange work going on in your community, that your administration and your health IT guy, if you got a guy or a gal that does your electronic health records or is thinking about developing one, that they're at those meetings, that your executive director is talking with the hospital systems about what they're doing, that your medical director is talking with other medical directors at federally qualified health centers, at mental health centers, so that everybody is talking. Because if you stay in your silo, there will come a time when these big hospital systems just start making decisions for you all. And now's the time. The jello is still sloshing around. Nothing's solidified yet. Now's the time to really make the move. So do the best you can with your clinical practice. You know, use some of this stuff. You're already doing great work, I'm sure. And then remind your team leader or your supervisors that they really need to get on board with this stuff. If you go to samhsaintegration.org, there's a technical assistance center that I work with there that has tons of information on health integration. There's just scads of webinars and white papers and all sorts of stuff to take a look at. Give your CEO, your COO that address. Have them call me, whatever it takes, because in order to protect your jobs and to make sure that the folks we work for get what they deserve, we really need to step up right now and during this time of health reform and do everything we can to continue to be able to do what we do. I'm just forwarding so you can have my email. So any questions or any big take-homes? Who wants to go to lunch? So that's where I can be reached. Thank you all so much for your time and attention. You guys are very attentive. I appreciate it.
Thank you.
Thank you.